The presentation tonight, we're going to be doing this interactively. The Q&A section there, not chat, is where we'd like you to post questions along the way so we can get them answered as we get to the end of the sections. And we appreciate your participation with us. Tonight, we'll have Dr. Pat Whitworth presenting, Dr. Shirag presenting, Shah, and myself. We appreciate your attention tonight. Okay, Pat.
Backing up to what we've known for a long time now, this is the Early Breast Cancer Trialist Group report from 2010, where they really looked at the 4 landmark randomized trials that proved beyond any shadow of a doubt that radiation treatment reduced the risk of recurrence, whether that's DCIS or invasive recurrence, after lumpectomy for DCIS. Radiation therapy reduced the recurrence risk by about 50%. And interestingly, and sort of surprisingly, there were absolutely no differences in metastatic disease, no differences in overall survival, even though that was a pretty substantial reduction, 50% reduction from 30% or so down to around 15%. Of course, only half of those recurrences were actually invasive cancer. So, as everybody knows, patients would prefer not to get radiation if it doesn't have a benefit for them. So we said 30% of patients would have a recurrence without radiation treatment. And again, half of those were DCIS and half were invasive. And the key here, or the question here really, is how do we identify the 70% of patients who really don't recur in 10 years? In spite of the fact that all they got was lumpectomy without radiation. We really want to identify those folks because if we can do that well, they don't need radiation and the attendant worry or sometimes complications that has with it. And in fact, if we kind of group the DCIS recurrences with the patients who have no recurrence, really 85% of patients didn't have an invasive recurrence, even though we know that the substantial majority of patients still get radiation treatment after lumpectomy. So this is just these are the curves from the actual publication of that Early Breast Cancer Trialist Group landmark trials meta-analysis. And again, about 30% of patients would recur without radiation, and that's cut almost in half or a little more than in half. And we want to be able not only to identify patients accurately who would not recur, but we want to be able to identify the patients who really would and really would benefit from radiation treatment. And that's the goal here. All along, for many, many years, and we certainly hear this in Tumor Board every week, we've used grade and age and size to some extent, but certainly grade and age as the way to try to identify folks who have such a low risk that maybe they don't need radiation or maybe they don't have a benefit from radiation. But what you can see here is that in that particular report, grade, even low grade, did not identify a group of patients without a benefit. Those patients who had low nuclear grade had a tremendous benefit, just like everybody else. Trying to put together the clinical pathologic features that we think mean a low risk of recurrence, the RTOG 9804 trial looked at smaller tumors, grade 1 or 2 with 3 millimeter margins, trying to identify that really lowest risk group of patients clinically, pathologically. But what was found in that trial over time is a substantial benefit from radiation treatment, especially at 10 years, and a significant risk for recurrence, especially from 8 or 9 years up all the way to 15 years of follow-up. So even the very best effort that's ever been made at identifying patients who won't benefit or who don't need radiation treatment doesn't show those classic clinical pathologic features to tell us anything, even though we hear about them every week in Tumor Board. The NCCN guidelines for a long time have said this. Basically, if you can figure out who has a low risk, those patients may be treated by excision alone. And a number of efforts have been made, whether it's nomograms or clinical pathologic combinations. But until we got genomic analysis to really reveal the biology of the lesion we're looking at, we really weren't making a lot of progress. Those things never worked. And Troy Bremer will tell us a little bit more about the details of this particular genomic assay.
Thank you, Pat. So this DecisionRT assay is a 7-gene predictive assay for radiation therapy. The score, the decision score, or DS, is a result of an algorithm that combines 7 biomarkers and 4 clinical pathologic factors. The biomarkers are shown on the top right. The clinical factors are on the bottom right. They're covering hormone receptor, HER2, proliferation, cell cycle control, stress response, and these clinical pathologic factors. They're combined with a nonlinear algorithm. So that means that the markers are used jointly, not individually. So for example, P16 is a cell cycle checkpoint, and if it is working and it's expressed, then we would expect the cells to not be proliferative, which is great. Unfortunately, sometimes it's abrogated. P16 is expressed, but you can still see the cell is proliferative. You could see that with a high expression of Ki67. The combination of those two things is what an algorithm combines, and that indicates a higher risk. So an algorithm is combining these multiple markers and clinical pathologic factors to produce the decision score. It's been validated in multiple clinical studies, and it's been validated to both be prognostic and predictive. We report 2 categorical risk scores on the historic validation studies. These are listed in the bottom left. In general, patients either have a low or an elevated risk category. Patients in the elevated risk category have a 70% relative risk reduction with radiation therapy. We'll talk about the absolutes of what that means in a minute. And patients with a low score did not have a significant benefit from radiation therapy. So when we talk about the score, this is not a Kaplan-Meier curve. This is a continuous risk curve. The bottom is showing the decision score going from 0 to 10. The left axis is invasive risk for the left side. The right side is total, either a DCIS or an invasive recurrence. The categories divided the groups into a low risk group and an elevated risk group for clinical trial purposes and reporting. The average low risk invasive risk at 10 years was 4%, and it went up to 15% on average for elevated risk patients. The hazard ratio was 4.2. And that was for a 5-point change from 2 to 7, for example. Patients on the right-hand side are going from quite a low score all the way up to 50. And those patients had a hazard ratio of 3. So the difference here is that not only is there a prognostic risk being reported, which is the breast conserving surgery line, there's also the risk after breast conserving surgery and radiation therapy. Some patients will have no to minimal benefit and no significant benefit from radiation therapy, and others will have a pronounced targeted effect. The way this report is that you have a score that's on the top line. The example on the left is a low risk patient group. On the right, we have an elevated risk patient group. The score on the left of 1 is being translated into what the 10-year total risk is of 8% or the corresponding 10-year invasive risk of 4%. On the right, a higher score is associated with a 28% total risk and a 20% invasive risk. After breast conserving surgery with radiation therapy, the patient would have a score of 1 has a very low difference, about 1% with the addition of radiation therapy, whereas the patient on the right-hand side with the higher score has a substantial reduction from 28% to 9% for total and from 20% to 7% for invasive. So patients are being identified with no to minimal benefit and with substantial benefit from radiation therapy. There's a third question, though, in addition to the ones that Pat raised. Not only are we interested in what the patients are who are at lower or higher risk and who's benefiting, we are also curious about patients who had a significant residual risk despite radiation therapy after breast conserving surgery. So it's these patients here on the continuous risk report that we were curious about. Why are these patients biologically at a greater risk? So the biomarkers, I've identified that in combination with clinical pathology. We were curious and we looked, and all of those patients were mostly HER2 new positive. Based on that and the new information we have on the biomarkers in the test, we know that some of them are likely associated with this particular phenotype. So in specific, HER2 has a number of different pathways that can follow after it's activated. And in particular, we have a KRAS pathway. The terminal end of the KRAS pathway has most recently been reported as being kept by CIA2 as the terminal gatekeeper. And of course, with KRAS being active, there are other characteristics of the cell survival, proliferation, and cell cycle progression that give it the aggressive phenotype that we're used to and that could be associated with increased risk. So we had a hypothesis that an activated KRAS pathway may identify patients with high residual risk after breast conserving surgery and radiation, and that this KRAS pathway could be identified using HER2 and other biomarkers from our set, including CA2. And we built a second algorithm that pre-specified this to combine that set of biomarkers into a novel residual risk subtype. So this molecular subtype that we're going to be discussing tonight. So when we talk about this molecular subtype, we have the algorithm that gives you a continuous risk score and the second algorithm that gives you the residual risk subtype. It's nonlinear. It's looking at estimating that KRAS activation in a clinical meaningful manner. And it's a pre-specified biological hypothesis that was provided to be evaluated by an independent stats group. Talking about how this test was validated and the residual risk type was validated with it, we have Dr. Chirag Shah.
Thank you. So to look at this study, we'll start with the study population. And this was a pooled multinational cohort of four cohorts. One was the UUH cohort from Sweden of about 358 patients, one the UMass cohort of 363, the other a KPNW cohort, 608, and then last the Royal Marsden in Australia, 485. And what's important to see is these are modern patients, right? So to get 10 years worth of follow-up is hard in a modern cohort. And here we have patients treated really in 1994 and beyond, with the exception of the KPNW cohort, which is 1990 and beyond. And all these patients had DCIS without microinvasion, no prior breast cancers, 10-year follow-up, and had complete biomarker and clinical pathologic features. So that was our total cohort of 926 patients. Next slide, please. And when you look at these patients, and we broke them up into those three risk groups, we really came up with these three risk groups based upon predefined biosignature risking. And so you have a low risk group, which is a decision RT score of less than or equal to 2.8 without the subtype, an elevated risk, which was a decision RT score of greater than 2.8 without the residual risk subtype, and then finally the residual risk subtype, which is a decision RT score of 2.8 with the residual risk subtype. And you can see about 37% of those patients were low risk, 43% elevated risk, and 20% residual risk. Next slide, please. Perfect. And what you can see here is when we look at the outcomes for these patients who had breast conserving surgery without radiation therapy, and this is about as clear of a separation of curves as you can see. So the green is the low risk, showing really low rates of any kind of recurrence. And this is in a no radiated cohort. The elevated risk with a higher risk of recurrence, and then subsequently the residual risk with a very high risk of recurrence without radiation therapy. And what this translated to numerically was a 5.6% risk in the low risk group, a 20.6% risk in the elevated, and a 42.1% risk in the residual. And both the elevated and residual were statistically significant compared to the low risk group. Next slide, please. I think what's interesting is when you look at the cohort and you start breaking down the features. The figure on the right, on the left, is kind of looking at different comparisons. And as we mentioned, the residual risk and the elevated risk versus the low risk group both had a significant increase. And then the low risk group had no benefit to radiation. So this confirms what was seen in the aforementioned studies by Troy. Then when we look at the elevated risk group, we clearly do see a benefit to radiation therapy. And we also found a benefit with residual risk patients. Going back to ClinPath, what we see is there really is no relationship. And once again, this is showing us that clinical pathologic features are not really giving us what we need when it comes to being prognostic and predictive. Next slide, please. So this is where we start looking at the benefits of radiation, because it's one thing to understand one's risk. It's another thing to be able to understand how treatment impacts that risk. And that's what this slide really looks at. So the low risk group, we're comparing in the blue patients who had lumpectomy without radiation to the purple with radiation. And you see no benefit with the addition of radiation therapy statistically in the low risk group. In the elevated risk group, you see a clear benefit, 16% reduction in recurrence with the addition of radiation therapy, which is also statistically significant. And then in the residual group, you see a 27% benefit in recurrence but also a relatively high residual risk of recurrence we see in the purple. And that's really what this figure is looking at. And you can see that it was quite statistically significant for both elevated and residual risk. Next slide, please. So what does this actually translate to for you and your patients? So if you're thinking about how many patients do I need to treat to help one patient? In the low risk group, if you radiated 100 women with a low risk decision RT, you would only help one patient, meaning a 1% difference in local control. Not very valuable by any measure of value. In the elevated risk group, though, now you're clearly seeing value, 1 in 6. So if you were to look at screening or other therapeutic decision-making models, 1 in 6 is clearly something where there's a clear benefit to an intervention. And that's what we're seeing in the elevated risk group. And the residual risk group, an even bigger benefit, 1 in 4. So really, the elevated and the residual risk groups are showing you that there's a clear benefit to radiating, and that the previous slides have shown us that clinical pathologic features weren't going to get us to this determination. Next slide, please. So what we're looking at here is the overall cohort of 926 patients, and then showing that it's consistent, right? One finding is great, but if you can show that finding to be consistent, it's even better. And what you're seeing here on the left is the overall cohort, on the right, the Kaiser and the RMH cohort. And what you're seeing is basically identical findings. So even when looking at these cohorts, you're seeing consistent findings in terms of benefit of radiation in the elevated residual, no benefit in the low risk, and increased risks of recurrence without radiation in the elevated and residual compared to the low risk, without any real benefit to clinical pathologic features in determining who those patients are. Next slide, please. And this is again showing that consistent benefit with radiation. So low risk not benefiting, elevated risk benefiting, residual risk benefiting even more, but still having a little bit higher rate of recurrence than you see in the elevated risk group, which really returns to a baseline risk after being given radiation therapy. Next slide, please. And what we're looking at here is really the overall population, looking with and without radiation as we discussed. And so you had that 42% risk of recurrence in the residual risk without radiation. You're down to 15%, but that's still pretty high. In contrast, you're at 20.6% versus about 4.9% in the elevated risk group. And when you look at the table on the right, what you're looking at is two things. You're looking at total IBR rate, or total local breast recurrence, and then below that, invasive breast recurrence. And what you can see is in the low risk group, no real benefit to radiation, and really low rates of invasive recurrence. In the elevated risk group, you're kind of seeing similar findings. And then the residual risk group, you're seeing, even in the patients who are getting radiation, that 14.7% risk of recurrence translates to about a 6.5% risk of invasive recurrence. And then these comparisons are residual risk versus elevated risk, showing that there was an increased risk of recurrence that was statistically significant for total recurrence rate, but it was not significantly different in invasive. When you compare residual risk to low or elevated risk, you get, again, a statistically significant finding for total ipsilateral rate and a trend for significance in invasive rate. Next slide, please. I think this is important to show in that the decision RT residual risk group is not all these high-risk patients you would try to pick out, but that low-risk clinical pathologic features are actually showing up in residual risk patients, which seems kind of illogical, but that's actually why the test is discriminating something that a pathology report can't. You can see low and intermediate grade. So these grade 1 and 2 patients we often consider omitting radiation, you still had a residual risk grouping of about, 8 to 10%. Similarly, low size, up to, 15 to 20% of patients were residual risk. And older patients over 50 were still seen in about 20% of the residual risk subtype patients. Next slide, please.
Thank you. So we have a little bit of a summary that we'd like to have Dr. Whitworth walk us through.
The first thing you notice is that there is a true low-risk group in each one of these cohorts that we've talked about. In developing the low-risk assay and the elevated risk assay, the UUH and UMass groups were used in development, and then there were validations within those, cross-validations. But then a large real-world set of patients independent of that original development group at the Kaiser Permanente Northwest showed us the very same thing. And then finally, we have what is considered level 1B evidence, where the prospective randomized controlled trial, SWE DCIS, showed exactly the same thing, 1% difference, which was not significant, which is really no difference. And then the combined modern cohort looks at the RRT subtype that really is defined by that activated KRAS pathway. And that was really looking at a hypothesis generated up front. So also another validation of what you've been seeing. Same thing is true in the elevated risk group. The elevated risk group definitely shows a risk reduction in each and every one of those groups, including the randomized control trial, SWE DCIS, and the combined modern cohort. What we hear, and I've mentioned this every week, is that we are trying to decide whether this lady needs radiation. We've heard she's got a genomic test result, but you know what? She's young and she's intermediate or high grade, or she's high grade. So we know she needs radiation, which reminds us of what? It reminds us of back when we used to say, we know who needs chemotherapy. We don't need a genomic test here because we know who needs it. And it turns out that was not true because we weren't understanding the biology at that point. And here we're in the same situation. Grade and age do not pick out the patients who have a radiation therapy benefit, and they do not pick out the patients who have a low risk to start with. They help and they're correlated statistically, but they can't really discriminate between those groups. So what we found in this comparison, looking at in particular these young patients or high grade patients, yes, there's a different distribution, and this is probably why you see a higher risk overall in younger patients or a higher risk overall in high grade patients. But this assay actually parses those out. You see, yes, a few more have residual risk in that young age or high grade group, and that's probably why those groups correlate in historical studies with higher risk. But here you can discriminate between those groups biologically, and then look what happens. What you see is that if you look at the overall population and that green column there, low risk group, breast conservation without radiation, breast conservation with radiation, no statistically significant risk, and low risk overall. What about the patients who are young, under 50, or who are high grade? Same exact thing, very low risk without radiation and no benefit with radiation. So whether you have an ordinary patient, maybe she's over 50, maybe she's intermediate or low grade, or traditionally what would be considered a high-risk patient, she's under 50, or you have high grade, which really strikes terror in the hearts of all radiation oncologists and surgeons, because that's what we've been taught over the years. There's no difference if you understand the biology, even in those younger patients. A few more young patients or a few more high-grade patients may be in these elevated risk groups, but if we identify what group the patient is in, this is what you see. So in the elevated risk group there in the column in the middle, you see a substantial benefit, both for the overall population and for that younger or high-grade group. And then similarly, in the residual risk column, the pink on the right, you see a very high risk without radiation and a substantial benefit with radiation, but still a residual risk that's higher than we would like. So this is just another graphic way of demonstrating these three groups of patients. These things are true whether the patient is an overall group patient or a patient we sort of traditionally think about maybe omitting radiation from, but it's also true for those patients who are young or high grade.
Thank you, Pat. So I wanted to just review a little bit of this, and we'll go through a few case studies in a moment. Tonight, we've talked about a number of different cohorts that have been used for the validation of the algorithm and the biomarkers for the DecisionRT test score, the decision score, so the continuous risk result, and also the same cohorts that we're looking at for Uppsala, Massachusetts, Royal Melbourne Hospital, and Kaiser Permanente, forming a modern cohort group that have shown that we have a residual risk subtype that's consistent between those groups. And the combination of those gives us new information. It's prognostic for a 10-year risk of recurrence. It's predictive for radiation therapy benefit. It's consistent between the studies. There's level 1B evidence for the prediction for radiation therapy, and it's consistent with the modern cohort evaluation. When you look within these groups, you have a low risk group defined by the DecisionRT test, and it has a very low IBR rate at 10 years without radiation therapy and no significant benefit from our radiation therapy after breast conserving surgery. You have the DecisionRT elevated risk group, and this is being defined as a score of greater than 2.8 without the residual risk subtype. And that has a significant radiation therapy benefit after breast conserving surgery and a low 10-year IBR rate after breast conserving surgery and radiation. And then finally, we have the new residual risk subtype. So this residual risk group has significant radiation therapy benefit after breast conserving surgery. It's got an elevated 10-year risk. And after breast conserving surgery and radiation therapy, there is still a residual risk remaining. Compared to clinical pathology, there is substantial reclassification for tumor grade, size, family history, and age. And when you look at this under a multivariate setting, none of those factors provided significant information after accounting for the test. Again, the residual risk subtype that we've been talking about is a novel biosignature that's in addition to the original score. It consists of a series of biomarkers. Key are HER2 and CA2. And these biomarkers have been combined with a novel algorithm in order to provide that residual risk subtype. So we want to talk about a few case studies, and then we'll open it up to question and answer. So the first study that we have is a 50-year-old female, right-sided intermediate grade. It was 1.2 centimeters for the extent of the DCIS. There are negative margins, and it was ER positive. And I'd like it if Pat can take this first one.
Well, in my tumor board, she would get a recommendation for radiation treatment, and she would be told that should put her in a position where she has a low risk of recurrence after her treatment. What you can see here is that she actually has a particularly high risk. She certainly has a benefit with radiation, but this is one of those situations we've been discussing where I would really want the radiation oncologist to know this and to be aware of this, that she's not the ordinary patient, and to really be employing anything that radiation oncologists use in this situation to get the very best reduction in risk for recurrence. I don't think we're in a position where we would say, well, if with this high risk, she needs a mastectomy. We don't have that kind of information. And in fact, you can see we do reduce her risk down to 7% for invasive risk recurrence, but it's something that everybody on the treatment team needs to know about. And I think this would also impact her surveillance after treatment.
And Dr. Shah, any comments?
Yeah, I'm in agreement. And I think that this may be a patient that you certainly consider doing a tumor bed boost. And I think we struggle with who to boost with DCIS, but this is a patient who, if I saw them in my practice with this profile, I would strongly consider a tumor bed boost in addition to standard radiation.
So the next patient is 48-year-old, younger, left-sided, intermediate grade, 1.6 centimeters, negative margins, and ER and PR positive. And Dr. Shah, if you'd be so kind to walk us through this one.
Yeah, so this is one where, on the flip side, we talk about, oh, she's under 50, I need a radiator. And that would be kind of your classic thinking. And I think what this tells you is kind of someone that you would automatically assume needs radiation may not. And so this would be a discussion where we say, really, there's not a clear benefit with respect to any breast recurrence, and more importantly, even invasive recurrence. There's no difference. And so this is a patient I would feel comfortable counseling on omitting radiation therapy in this situation.
So the next patient is a 73-year-old female, right-sided, high grade, 3.1 centimeters, negative margin, ER negative, and PR negative. And it'd be great if we can start with Dr. Whitworth and then get commentary from you as well, Dr. Shah.
Yes, this is a patient where typically we would hear in tumor board, she needs radiation treatment. She's older. She has a high-grade lesion. It's ER negative, PR negative. It's 3 centimeters. And almost anyone in that tumor board is going to be afraid that she's going to have a very high risk for recurrence without radiation. And you can see you get a nice readout for what her risks are. And I frankly use this report to go over risks with the patient. We know that if we're talking about invasive risk, that's a little more risk, but her risk is 7% without radiation, and it does go down to 4% with radiation. This is something that just depends very strongly on the patient's preference. Some patients will look at this and say, man, I want that treatment. I want that reduction from 7% to 4%. And other patients with an informed discussion with this same information will say, no way, I'm doing radiation. That's not enough benefit for me. And I know we're not talking about a survival impact, and I'm just going to follow up with my mammogram. So patients really divide themselves, and it's much quicker, much more efficient discussion if you can give them good information about what they're deciding.
Yeah, I would have to agree, Pat. And I think, there was a comment in the Q&A of how do you get radiation oncologists to buy into this test? And I think it's about telling them that you're picking the right patients for your treatment, right? So as a radiation oncologist, I certainly don't want to radiate women who aren't going to benefit from radiation therapy. And on the flip side, I don't want to recommend omitting radiation for patients that I could help. And to Pat's point, this is where there's a risk-benefit discussion and saying, there are some people who will see the 7% overall benefit and 3% and say, no, I don't want radiation. That's absolutely okay. Some may say I want radiation, but this is individualized data for that patient to consume and to have an informed discussion. And I think that's really important. At the end of the day, this is offering patients as well as clinicians the ability to individualize their discussions regarding treatment options with the patient and really tailor therapy to those that need it and omit therapy for those that would benefit from that.
Right. So one last one. This patient is 73 years old, right side, intermediate grade, very small, negative margins, ER and PR positive.
Yeah, this is a patient that in the past I would say, oh, I don't even need to see a post-op. Let's skip the radiation and we'll get a mammogram. And I think to the comment that was made in the Q&A, this is the other side of the coin that people don't often discuss, which is we want to avoid under-treatment as much as we want to avoid over-treatment. And this is a patient you look at and everything, in the case presentation is low risk, no benefit, and clearly a huge benefit to radiation therapy. And also, as Pat had mentioned, considering, maybe a more advanced follow-up screening, this is a patient who may benefit. So I think this is where sometimes, I tell people, I want to know the wolf in sheep's clothing, and this test gives me that ability.
Yeah, we saw decisions change in the PREDICT study, looking at what clinicians did at major programs around the country. Decisions and recommendations changed dramatically from what the radiation oncologist or the surgeon had recommended up front without the test once they got the test. And so it went in both directions. Patients who initially, based on ClinPath, would have gotten a recommendation for no radiation. Many of those got a recommendation for radiation after they got a biologically informed report. And it went the other way as well. So the goal that we have here is the same goal we had when we were treating everybody with chemotherapy, and we knew it wasn't helping most of the people that got it. And the same thing is happening here now that we can identify the folks who really do have a risk and have a benefit, and then the folks who have less.
That's great. So there was a question that was associated with what is happening with microcalcifications that show up after surgery. And in the analysis of this data, there was a requirement that you did not have a recurrence within the first 6 months that would be censored. As it turns out, all the patients who had negative margins didn't have a recurrence within the first 6 months of screening. I believe if they had had positive microcalcs, they would have gone back through with screening and been identified as having a recurrence. But in our case, for these patients, there was not an event that occurred. There was another one that was raised, and this was patients who were analyzed in this test in the modern cohort of 926 patients. This was for in-breast recurrence, either local or regional. And the metastatic recurrences were not explicitly included. And that was part of the design for the study. So it turns out that there is a very low rate of metastatic recurrence, and they, of course, may be associated with other invasive events prior to them. But this study is specifically looking at a local recurrence rate or a local regional recurrence that's being reported for the total and for the invasive. Pull up one other question. So there was a question about margins and low risk. So if you have a patient who has low risk and you have a patient who has close margins, how do you deal with that? And I'd be happy if either Dr. Whitworth or Dr. Shaw could talk about that.
Well, in the first place, there was a sort of confusing consensus panel recommendation that if you read the paper in some depth, what the paper says is that you really should go back for ink on tumor. But ideally, you'd have 2 millimeters. And basically, that's what they said. And they said if you have less than 2 millimeters, you need to think about that case. You need to think about it. Is she really young? Does she have a high grade lesion? Without understanding the other factors involved, less than 2 millimeter margin is not a reason to do a re-excision and not a reason to change to mastectomy. I think this biologic information dramatically improves your thinking about this situation. If you have a very high risk and you've got a very close margin, maybe it's less than a millimeter, but clear, no ink on tumor, and you have an elevated risk, I think absolutely you really have to go back and either do radiation treatment or get a re-excision. And in fact, with a high risk, that's what you're going to do anyway. You may be able to be comfortable avoiding radiation if you go do a re-excision and you have a low biologic risk, a low decision RT score. Chirag, did I say that clearly?
Yeah, I think that the takeaway is that it's not, I think people took that guideline to say 2 millimeters or bust, and I don't think that's true. It's 2 millimeters and then between 0 and 2 counseling. And I think what the decision RT lets me do is order a test on someone who has no tumor on ink and feel comfortable if it's low risk to not give radiation, not do anything else. So I agree. It's not mastectomy if it's under 2 millimeters. It's not forced re-excision. It's really thinking through things, talking to patients, and using tests like this to help best decide what's needed for the patient.
And the margin definition in these studies was no ink on tumor.
Yeah.
So I think that's consistent.
There was another question that came up that was associated about ER/PR positivity and what type of validation was done for patients who are ER/PR negative. So in the study cohort, most patients who are high grade, for example, tend to be ER/PR negative. And overall in the study cohort, about 30% of patients fall into that category where they're not hormone receptor positive and 70% do. So when you look at patients in our overall performance group, those patients with high grade are much more likely to have that non-hormone response positivity remaining. And yet we've shown specifically in patients under 50 and high grade patients that those patients in the low risk group do in fact have a low risk, even though they have the categorization of being younger or high grade. And there weren't statistical differences.
Yeah, Troy, we had the pleasure of presenting an analysis of endocrine treatment benefit at the last ASCO meeting. And the findings in that analysis of some of these patient cohorts, these same cohorts, were really kind of interesting. Endocrine treatment did not appear to benefit the patients substantially who were in that low risk group. On the other hand, if you took all of the patients in the elevated risk group, and I'm excluding that residual risk, that elevated residual risk group, just the regular elevated risk group, there did appear to be an endocrine therapy benefit. But when you broke it down, the endocrine therapy benefit was really pretty big in the elevated risk group patients that didn't get radiation. You had an elevated risk group patient and she didn't get radiation. She had a pretty substantial benefit from endocrine treatment. If she got radiation, she had some little benefit from endocrine treatment, but it looked like the exact same benefit that you got in the opposite breast in terms of reducing new primaries. So you can have new primaries in the treated breast, just as you can have them in the contralateral breast. And that was about a 4% difference in the contralateral breast and about a 4% difference in the index breast after radiation. So if you're in a situation where you have a patient who has elevated risk, but for one reason or another has chosen not to have radiation, that would be the group that I would certainly want to target with a recommendation to consider endocrine treatment.
Dr. Shah, what would you like to say about patients who are hormone receptor negative?
Yeah, I mean, I think there's a twofold point there. I think one is Pat's, which is low risk patients don't benefit from endocrine therapy, anyway in this testing and in this study. And then the second is that I don't view ER negative DCIS like I view ER negative invasive cancers. I think we sometimes try to conflate those two. And so from my standpoint, ER negativity is not driving things in the same way. And so I feel very comfortable in a high grade patient, many of whom are ER negative. And the data we have shows that low risk patients, even in that high grade group, don't benefit from radiation. So I have been able to move away from those features, feeling very comfortable based on the multiple validations that have looked at things like age and grade in this situation.
It really is difficult for experienced clinicians who have been, taking care of patients their entire lives to move away from what they really were trained with, from all the information that they used in every tumor board up to the time a new finding like this has appeared. And I can certainly remember when we were first getting information about the 21 gene score and even about the 70 gene score once the randomized trial was presented. Clinicians had a very hard time moving away from what they'd done their whole lives. And I expect we'll see similarities here, especially radiation oncologists who've been relying on grade and age their whole life.
Yeah, and just to the point, I think there was a question about how do you convince radiation oncologists? I think, obviously, it's something that continues to grow. It's something we use in my practice in Cleveland. And I always tell people, if you ever have questions or if your radiation oncologist has questions, reach out to someone like myself. I'm always happy to discuss how we use it in my practice and why we use it in my practice and why we think it's a benefit to patients first and foremost.
Yeah, there's another associated question, and that's when you look at the reproducibility of this test, and you also look at reproducibility of factors like nuclear grade. We know that there's been multiple studies on nuclear grade, and you often can have differences in pathological assessment when you look between centers for nuclear grade. And so you can have a patient who's grade 2 at one group, and they could be grade 3 in another. And likewise, you could have someone who is grade 1 who is also considered grade 2 in another group. And there's multiple recent publications on this in different countries, including the United States. The same is similar for the definition of really what is cheminonecrosis and necrosis itself and how often it's called. So when you're looking at this test, the data shows that when you look at reproducibility, we have multiple pathologists who are used to evaluate the score. They're doing it independently. We have a 0.5 unit threshold for consensus. If the difference between independent validations is more than half a point, it's required to go through consensus. So we hold those calls very closely for the test as part of a centralized lab. So in some cases, I think that you have patients who are grade 3 because of a particular call, and they might have been grade 2 otherwise. And also the converse is true, that you have patients that are grade 2 and some calls are grade 3. So I believe that this test can help with more consistency in evaluating the risk profile than the independent clinical pathologic factors. Another related question is, how do you look at this in context of RTOG 9804? So when you see a patient who meets that low risk criteria, and yet they have a high decision score, how do you proceed with treating that patient? And I think that'd be a question for both of you to direct.
Well, Dr. Shah, I think, did a specific analysis of those criteria within the patients we've studied.
Yeah, so we've looked at 9804 and ECOG 5194, which is, 9804 is basically the low risk group of 5194. And basically you show within that, you're going to have patients that are high and low. And it's kind of almost like a coin flip, which is disconcerting to me because I used them for, before I had this test available. And what you're realizing is that these criteria are basically a coin flip between low and high, and that they're not really giving you any benefit in picking low and high patients. So, I think there's a nice set of data that shows, when you look at the high risk patients, about a third of them actually convert to low risk. And when you look at the quote unquote low risk based on 9804 or 5194, about 45 to 50% flip to elevated. So what that tells me is that there really is no utility of using 9804 criteria in radiation decision making at this time.
It's great. I'm also curious about treatment modalities. What do you use for patients diagnosed with DCIS, and how do you decide how to vary those modalities?
Yeah, so well, for low risk, I don't use any modality. We avoid radiation in low risk patients. In elevated risk patients, most of the time, if they meet other criteria, I'm typically offering them 5-fraction partial breast, or if they're not interested in that, some kind of whole breast regimen. And if they're residual risk, I'm going to be talking about tumor bed boost and things like that. So whole breast with a tumor bed boost. So I think that's kind of how I think about radiation modalities using these kind of 3 categories.
That's great. So one of the other things that comes up for new clinicians who haven't used this test is, how does this work in your conversation with your DCIS patient? Does this make it easier or harder, or what's your experience with it?
As a radiation oncologist, I think we use it in 2 ways. So, and obviously Pat on the surgical side will kind of mention his thing. So if I'm seeing the patient preoperatively in conjunction with the surgeon, I'll usually bring up the test at that point, obviously having talked to my surgical colleague about it and talking about what the test is, why we use it, and really how we will use it to shape their decision-making. And oftentimes the patient will ask for it to be run on their biopsy even before surgery. So when they get back from surgery, we have both their final pathology and their decision RT score. That being said, some practices, including the ones I used to work in, oftentimes I would see the patient post-op rather than pre-op. And in that case, I'll talk to the surgeon on the phone or shoot him a text. And then I would then talk to the patient. And if they're interested, order their test and make the decision. Typically, the test turnaround is quite quick so that it doesn't delay radiation therapy in an elevated risk patient.
Yeah, for me, we really get this test on our biopsy material. And we have to pay attention to the clinical size because that's part of the assay. But the biopsy material allows us to really tell the patient what we might expect before we have to get there with the decision making. And I've actually seen it make a big difference for a patient who says to me, I want a mastectomy. My grandfather was killed by radiation treatment. I'm not about to have radiation, whatever I can do to avoid radiation. And if I can tell her, we analyzed your tumor tissue and you are not someone who will need radiation. If we can do a lumpectomy with a clear margin, you don't need radiation. And so you would not have to have that. And that puts you in a position where you could have a lumpectomy instead of a mastectomy. So for me, it's most helpful to get it as early as possible in the treatment pathway for that patient, because we've made patients wait a long time, and we really started making them wait quite a long time when we started doing genomic testing because it took so long. And I think some people just would make a decision and say, let's go ahead and give chemotherapy, or let's go ahead and give radiation because I don't want to make you wait any longer. Let's just get started. So for me, as early as possible in the treatment pathway. I think I don't know what the breakdown is as far as where people get this, whether they're getting it on the biopsy all the time or waiting for the tumor tissue.
Yep. One of the questions that comes up with response to that, Pat, is how this is used across the country and whether it's on biopsy or the excisional or both. So in our experience on the smaller tumors, the best representative tissue is often in the biopsy. In fact, we'll frequently have to request the core biopsy material after we look at the excisional and find there's nothing left in it except bovine hematoma. And so we'll go back and ask for the original core biopsy material. So as you're using it in your practice, I heard that you're using it often from core biopsy on small lesions. Our recommendation is that it's up to 1 centimeter where the core biopsy is really optimal. When you have larger tumors, we do recommend that you use the excisional so we can make sure that we do good biologic sampling. And so it's really preference and practice. And there are some groups where a lot of the ordering is done on the excisional by the surgeon, and then that's handed off to the radiation oncologist. And in some cases, it's done where the radiation oncologist is placing the order themselves. So it really depends on the institution. There's another one which really comes back to residual risk, and it was can you tell the difference between the residual risk subtype in that group and decision score? So the residual risk subtype is a molecular subtype. It's only made up of biomarkers and an algorithm. It is predicting those patients who are at a particularly different risk profile after breast conserving surgery with a higher risk of recurrence after radiation therapy and breast conserving surgery. That residual risk subtype is a molecular subtype. The decision score is a biosignature. It is a continuous risk score. It's predicting the risk after breast conserving surgery, and it's predicting the benefit from radiation therapy. The combination of those is what we presented as the risk groups so that it's easy to have a clinical discussion about that. So both the decision score and the risk subtype. So that brings up the question, if you have a patient with this higher remaining risk, the residual risk subtype, what would you think would be differences that you would be considering when you're having that discussion with your patients?
Well, in the first place, I'm glad you brought this up because I know we've been discussing this. I'm hoping you may hear from some of the people that are on the webinar, because we've discussed how do you report that to the clinician in the first place. And do you just let the graphs tell the tale? Do you just let the report graphics that show where you start without radiation and where you end up with radiation? Do you let that inform the clinical decision making, or do you somehow let the clinician know? And I know we've heard from some clinicians, we don't want to terrify the patient. We don't want to, make her think she's in a terrible situation, but I feel like we want to inform the doctors. And I think you'd probably love to hear from the folks on the webinar about that. But, the expert here about how that modifies what you're doing is Dr. Shaw. And I heard him say he does think about these patients differently.
Yeah, I would agree. I think that we don't have a perfect answer in terms of data saying what strategies are going to be most effective, but I think we try to use kind of first principles. And so in a patient who I think has a higher risk of recurrence, I give them a boost. And that seems to be based on data from boost trials, as well as data from Australia, New Zealand on boosted DCIS patients. So that's my first go-to in my armamentarium. So I think that's a really good way to go. And then as time goes on, we'll obviously continue to evaluate that approach and see if there are other things that need to be added additionally.
Great. So I believe at this time we don't have any other open questions. And if you two either would like to make final comments, this would be the opportunity.
I think the only thing I would say is that this has been really a game changer for my practice, I think, in the sense that it's funny, patients know things that I think that surprise us. And I can tell you how many patients now come into my office asking me about this test in particular has been surprising to me. I think patients really want their treatment tailored to their individualized risk, and this gives us the ability to do that. And as I had mentioned, I think throughout this talk is that what surprised me is that I'm still surprised. I'm able to be surprised, and that patients I assume that would not need radiation clearly need it, and patients who I assume clearly need it don't. And I think for us to think that we know that, and even someone who specializes in breast cancer, I remain to continue to be surprised. And that's why I continue ordering the test, because it's giving me something that I can't find anywhere else in my clinical information.
Sorry, Pat.
Just in terms of workflow, having these discussions with patients can be difficult. And the more information, the more precise information we have, it's a much more efficient discussion. And not only that, the patient feels like they have really been listened to. They feel like they've really been given good information because you have something to hang your hat on. And if you're just talking about more general kinds of risk, that tends to be a much longer discussion, and the patients tend to leave it unsatisfied. So I think having some real numbers and graphs to show the patient and talk about can make a much more efficient workflow and make a much more satisfied patient at the end of that discussion.
Great. Thank you both for your time. Really appreciate the expert opinion. And I thank you for all of the participation for those people who are joining us this evening. Have a great night.
Thank you.